Good morning. Welcome to meeting number 2 of the House Budget Review Subcommittee on Health and Family Services. Chairman Bentley is on his way back. He's stuck in some traffic, so I'll be taking, the gavel this morning until he gets here. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the secretary call the roll.
Representative Bowling.
Here.
Representative Fleming.
Here.
Representative Raymond. Representative Wilner.
Here.
Representative Petrie. Representative Reed. Representative Heverin. Representative Moser. Chair Bentley.
Thank you, and I believe we'll have to hold off on the approval of the February 8th minutes. We do? Okay, never mind. Next, we'll have approval of the minutes from the February 8th meeting. Do I hear a second?
Second.
Thank you. Minutes are approved. All right, to start this morning's meeting, we're going to have a couple of presentations regarding Home and Community-Based Services Waiver Program. First up are Pam Smith and Leslie Hoffman with the Department for Medicaid Services. They will give us an update on the number of waiver slots and waiting list. And Ms. Smith and Ms. Hoffman, if you guys will please identify yourselves for the record.
Good morning. My name is Leslie Hoffman. I'm the Deputy Commissioner for the Department of Medicaid Services. It's an honor to be here today.
My name is Pam Smith. I'm the Division Director of Long-Term Services and Supports, and so we oversee all of our home and community-based 1915C waivers.
Thank you all for being here. The floor is yours.
Okay, I'm going to start off with the presentation and go about halfway through and then turn it over to Pam. So I'm going to go over the 1915C home and community-based waivers, enrollment, waiting list, and a couple of tips about how CMS expects us to keep those numbers in line. So the first slide you'll see, this is busy, so I'll just go through it slowly. So we currently have 6 1915C home and community-based waivers, and this is the enrollment. As you can see, we have the acquired brain injury acute waiver, the brain injury long-term care waiver, the home and community-based waiver, which was our original and why the name is the same as the overarching. We have the model waiver 2, the Michelle P. waiver, and then we have the supports for community living waiver. If you go down to the first line of the grid, you'll see the funded slots, 383, 438, 1750, 100, 10, 5, and in all transparency, we saw a mistake this morning. That should be 4991. We've looked at these numbers so many times that we've missed it, even though we've looked at it many times. So it should be 4991. In the field slots, you'll see 231, 429, 15076, 24, 10,077, 4,856. In the reserve slots and the available slots, you've probably heard us speak about this before. It's very fluid. So we have a time period that's between 90 and 120 days. We have an opportunity that a slot funding or allocation has become available. We may reach out to the member and or the family member many times to see if they're interested in it, so that they can go forth if they are interested and ensure that financial and waiver eligibility is acquired. And sometimes they may decide that they don't want the waiver. And if they do decide they don't want the waiver, then that slot can just go back into the reallocation. But it is fluid for about 120 days. Does the waiver have a waiting list? As you can see, both of the acquired brain injury waivers do not have a waiting list. The home and community-based waiver, as well as Model 2, also do not have a waiting list. Our Michelle P. waiver and our supports for community living waiver, however, do have waiting list. Please note, I wanted you to know that 50 slots will be eligible or will be allocated for the Michelle P. waiver and for the supports community living waiver fiscal year 23 and in fiscal year 24 upon CMS approval. So even though we're told that we can go forward, we still have to get CMS approval. So let's talk a little bit about allocation. The Center for Medicare and Medicaid Services, CMS, requires waiver slots to be unduplicated, and a lot of folks ask about that, so I wanted to share that with you today. CMS defines an unduplicated waiver participant as a unique individual who participates in the waiver during the waiver year, regardless of when the individual entered the waiver and the length of stay on the waiver. A person who enters, exits, or re-enters the waiver during a waiver year counts as one unduplicated waiver member. So in essence, if a member uses a slot one 15-minute increment, then that is their slot for the entire waiver year. Think of the participant as the owner of the waiver slot. If they leave the waiver for any reason, they still own that slot, the waiver slot, until the end of the year is over, and that's the waiver year. The empty slot cannot be given to anyone else. This is unfortunate, but this is what CMS asks us to do. If the participant is actually actively receiving services when the waiver year ends, they become the owner of that slot. So unfortunately, within the waiver year, say if a waiver year starts July 1, let's just say July 1, and on July the 5th they leave, we cannot reallocate that slot for over 300 days to another member until the new waiver year. Now that member can take that slot back within that same given waiver year. And waiver years do vary based on the waivers the 6 waivers that we have, timeline-wise. Currently, the 1915C HCBS wait list are for these two, Michelle P. and SCL. We have a total of 8,021 on the Michelle P. waiting list. For your knowledge, we have under age 21 is 5,547. So that's just to let you know, out of the 8,000, 5,547 are children. The Michelle P. waiver applicants are placed on the waiting list in order when the application is received. On the SCL waiting list, we have 3 levels or categories. I think that's how we define it. So we have the emergency, which we have 0, urgent, and in mine process, that's about 1 to 3 years. I'm going to need services in 1 to 3 years. And future planning, which is 5 or more. SCL applicants are placed on the waiting list based on their category of need. Once that category is determined, applicants are placed with the category on a first-come, first-served basis.
Okay, so as Leslie just went over, you can see about 70% of the children or the individuals on the Michelle P. waiting list are children. So the Cabinet, Medicaid, has taken on a children's waiver feasibility study. So again, this is just a study at this point to research and consider what supports and funding is necessary for children in the target group, which I'll go over that in just a second. It's being led by our consultant group, Guidehouse. The study has just began. We are researching states that serve children, looking at the programs they have that serve children, the services they offer. We also have a stakeholder advisory group that is comprised of Cabinet staff from Medicaid, the Department of Behavioral Health and Intellectual Disabilities, the Department for Aging and Independent Living, the Department for Community-Based Services, as well as parents, advocates, provider groups, the Kentucky Mental Health Coalition, and we also have a couple of teenage children that their parents are participating, so they also have sat in on that first meeting and were able to participate. So we know that children with severe emotional disabilities are in hospitals and unable to be served at home, and that there are currently many children with intellectual disabilities and related conditions, including children with autism spectrum disorder, on existing waivers or on a waiting list. The existing waivers today are focused on an adult population, not necessarily the distinct needs of children, and program designs need to reflect the needs of a pediatric population. So what must we do? We need to create pathways to modernize by looking at what are the services they need, what is necessary to have the child remain in home in the least restrictive setting but still get their clinical needs met by best practice services. We need to look at our provider network, determine what their capacity is and their readiness to serve children. What additional training will they need? What additional providers are we going to need? We have to look at that cost. What is it going to look like to serve a child through a 1915C home and community-based waiver if that is what is determined to be the best route after this study? And we're conducting that comprehensive study in a very transparent way to legislators and stakeholders. We're going to have multiple public input opportunities. The information will be posted on our website, including meetings, as well as we plan to send over materials regularly updating the legislator on our progress. So to talk about a little bit about the groups that we included. So severe emotional disability, we're looking at any clinical significant disorder of thought, mood, perception, orientation, memory, or behavior that is listed in the current edition of the American Psychiatric Association's Diagnostic and Statistical Manual of Disorders. That is a mouthful. We're also looking at conditions related to intellectual disability. So these are our children who require physical or environmental management or rehabilitation. They require a planned program of active treatment. They require protected environment, and they have substantial deficits in adaptive functioning with ongoing sport that would limit them in one or more activity of daily living. So think of this, a lot of these are children that have cerebral palsy or that may have epilepsy or another seizure disorder. And then lastly, our autism spectrum disorder. So a developmental disability that can cause significant social, communication, and behavioral challenges, including autistic disorder, pervasive developmental disorder, not otherwise specified, as well as Asperger's syndrome. And so lastly, we're going to talk a little bit about our rate study findings. So in addition to CMS requiring a sound rate methodology, its expectation is that rates should have parity across programs amongst like services. Currently, we have a rate disparity among our 6 HCBS waivers. This not only gives an appearance that one population is more important or deserves more services than another, but it also draws providers to serve one population over another. From February of 2022 until January of 2023, we have been conducting a comprehensive rate study across the majority of all of our 1915C HCBS waiver rates to develop this sound payment rate setting methodology, as well as to look at addressing the disparity. The rate increases are intended to be long-term policy change, giving Kentucky the sound and defensible rate methodology that can be adjusted over time and allows for rate setting decisions based on economic and operational factors. The findings of the completed rate study are bolstered by strong provider survey participation rate, along with sound nationally recognized external benchmarks. We had an over 70% participation rate in the survey. The rate study reviewed and considered the actual cost to provide services as told by our current HCBS waiver providers. This rate study, in contrast with the previous one, was not done under the constraint of it being budget neutral, so avoiding that winners and losers appearance. The need to meet Kentucky's most vulnerable HCBS citizens must be accessible, high quality, person-centered, and available in the least restrictive setting of care in the person's community of choice when possible. Investing in the rates is a necessary step to offering this quality of support to individuals in need of HCBS, and also to avoid unnecessary institutionalization when possible. So allowing individuals to age in place and continue to be in their community where they have grown, they have friends, and they would like to stay involved. Our waivers have seen growing enrollment and utilization, which reflects how critical HCBS is for Kentuckians who need long-term care. We are currently evaluating the potential budget impact. And so what are our next steps? So we are committed to ongoing transparency and information sharing in collaboration with our federal partners who must authorize any rate methodology and resulting rate increase. So once the impact has been thoroughly assessed, we will be sharing that information. But I wanted to share what we've done so far to help providers, because I know that sounds like a lot of time. There's been a lot of talk about rates and rate changes. So what have we done so far? So as of 1/1 of 2022, we raised multiple direct service that individuals receive in the community. So think attendant care or help with their personal care. Those really direct, hands-on, non-clinical services that allow an individual to remain in their home. This allows those providers that attest to pass 85% of the increase, which was up to 50% of their base rate, to the direct care workers in the forms of either wages, training, bonuses, so sign-on bonuses, retention bonuses, really directed at trying to bolster the workforce. So those services were attendant care, community guide, community access, community living supports, homemaker respite. So again, those services really directed at providing that hands-on assistance to the individual. In addition, the SCL Level 1 and ABI Residential have also been able to build the 50% increase since January 1st of 2022 without a limitation. Prior to that, they were able to bill it if the individual was not going to an adult day training during the day. We've issued one round of retainer payments to adult day healthcare centers and adult day training providers in 2020, and we'll be issuing a second round to providers who applied and qualified in the next 2 weeks. Individual providers are going to start being notified at the end of this week of when they can expect to see their payment and us to verify their address, for example, just kind of the technicalities of last things we have to do before we could issue that. We have received approval to use the enhanced FMAP or the ARPA funds. You kind of hear those used interchangeably, as outlined in House Bill 1 for the rate increases for the 10% in fiscal year 23 and 10% in 24. We are currently waiting on the final approval from CMS of the Appendix K amendment, which allows us to go ahead and pass those rates through to the providers without having to modify the regulation and modify the waivers until the final rate study is done. So it allows us to get money into the hands of the providers sooner. So I know that was a lot of information in a very short amount of time, so I'm happy to answer any questions.
Thank you very much. Are there any questions from members? Representative Fleming.
Thank you, Mr. Chairman. I just want to get some clarification, if you don't mind. On your, I guess your matrix on, I think, slide 3, that shows funded and filled rates and so forth. You mentioned in your presentation that the individuals can might be enrolled, but they may vacate it for whatever reason. Is that represented in your available slots?
It is not. They actually are included if they vacate within that waiver year, because that waiver year, that slot will remain theirs. They actually show up in the filled slots. So you may see individuals in that filled slot number that are not currently accessing services, but at any time during the waiver year, they may come back and come right back into that slot.
Could you peel that back a little more? So let's say the filled slots for Michelle P. It's 10,077. How many are not filled?
I do not have that number with me, but I can go back and I can get that number.
Okay. Yeah, if you can just get up to staff and they'll distribute out to folks. I'm just trying to see exactly what's going on. I assume that's more of a federal requirement in order to make that do. Then that's probably like moving a battleship 1 degree and it won't happen. But I just want to get that clarification. And also, and I probably should know this, but I think I've seen numbers in the past. Can you assign or give me some like a cost allocation of each one of these programs and the costs that's associated with that, and so I can get a better feel?
Yes, so I do have the our average cost per slot based on our last report to CMS. So they lag about 18 months behind based on claims coming in. But these are based on the last accepted reports from CMS. So for the ABI Acute program, and I can send this over in writing after as well, it's $106,263 cost per slot. ABI long-term care, $106,263. ABI long-term care is $86,714. The home and community-based waiver is $25,967. The model waiver 2 is $145,233, and that that waiver is the one that serves individuals that are technology dependent, so it is 100% skilled services. So that's why you see a high cost for such low member numbers, because the services that are being delivered are actually for up to 16 hours a day of skilled nursing care for those individuals. For Michelle P., the average cost per slot is $41,732. And for the supports for community living, it's $92,699.
I'm sorry, Mr. Chairman. I'm take a little liberty if you don't mind. I've just been up here. Thank you. Yeah, if you can send those, or actually, if you can just take this spreadsheet and then assign the cost into that as well.
Okay.
I appreciate that. So when you say cost, and could you peel that back a little more? There's costs and loaded costs. How do you define your costs? And are you fully covering your costs? You may say it's costs, but there's other things that go into a cost that I know of. And is that being reflected in your numbers you provide, or is this a sort of a underestimating or under cost analysis of that? Because if that's the case, then we're upside down, and we need to figure out what we need to do in order to cost justify or cover that, if it's a possibility.
Yes, so it actually is the cost based on the claims. So it's based on what we are paying for the services that are provided, and so it is an average cost. So you do have some individuals that are they're coming in at higher, some that are coming in lower to get that, but it is based on all the services they receive in the community to remain in the community. So it is their waiver slots, as well as if they are getting other services, that goes into that to get that average cost for that person to be served in the community.
Okay. All right. Thank you, Mr. Chairman.
Representative Mosier.
Thank you, Mr. Chair. And I just have a quick question. And thank you for the presentation. It's a lot of information. On the unduplicated waiver participant, it's concerning to me that CMS is requiring that slot be filled no matter how many days an individual uses it, obviously tying up that slot. Is there anything that the state can do to rectify that situation? I mean, outside of, comments to CMS, do you know if CMS is looking at some of these barriers that they're creating?
We actually have had the discussion and had the question with CMS, particularly over if an individual unfortunately passes away, because obviously they're not going to come back and access that slot. They did commit to looking at that, but again, that's not just Kentucky that has reflected that. It's been other states. The driving force behind the unduplicated slot is really to keep individuals who, for no fault of their own, they, say they fall and break a leg and they're out of services for 60 days, which would require them to be discharged from the waiver, them potentially having to go back on a wait list or have services delayed. But there has been discussion with CMS, and I think will continue to be discussion on that unduplicated slot, because there are some things, as you point out, that don't make sense. Especially if you think somebody uses a slot for one day, and then you have individuals waiting. But unfortunately, we're restrained by our federal partners there and what they let us do.
And that's not a new rule. CMS has always enforced that.
Yeah, in the 20-something years I know that I've done waivers, it's been.
They used to do regional allocations, and that went by the wayside probably 25, 30 years ago.
Okay. Well, if there's anything we can do to highlight that, let me know. Thank you.
Thank you. Any other questions for members? All right. Thank you all very much for your presentation today.
Thank you.
Thank you.
And next we have Miss Amy Stade, who represents the HCBS waiver providers. She is here to discuss implementation of the reimbursement increases for waiver providers included in House Bill 1.
Hi.
You'll please identify yourself for the record.
My name is Amy Stade, and I am the CEO of the Kentucky Association of Private Providers. Let me get situated here. Sorry. Hi again, and thank you for allowing me to be here today. Again, I'm Amy Stade. I am the CEO of the Kentucky Association of Private Providers. We are the trade association representing providers of services through Kentucky's 1915C waivers, specifically focused on individuals with intellectual and developmental disabilities. These services are generally provided through the SCL and the Michelle P waivers, but some are supported through the home and community-based waiver. This allows individuals to live in the least restrictive setting and live in their communities instead of state-run institutions. I was asked to come here today to provide the committee with an update on the implementation of rate increases that were included in the last budget for Kentucky's 1915C waiver services. Of course, I can only provide the provider perspective. I don't work for the Cabinet for Health and Family Services, but I'm here today to provide that perspective. First, I thought the committee would like a little background information about how we got here. So in 2021, the General Assembly formed a task force called the 1915C Waiver Services Task Force. And it was to study Kentucky's 6 1915C waivers and develop findings and recommendations. You all saw a slide from the Cabinet about the Kentucky's 6 waivers, so I won't go into what they are. That task force met over the 2021 interim and adopted findings and recommendations, which recommended both short-term and long-term funding solutions to address, among other things, the significant workforce crisis experienced by providers in all 6 waivers. Since before the pandemic, Kentucky's waiver providers have faced tremendous challenges to deliver care. The pandemic exacerbated the ongoing workforce crisis. Kentucky's waiver providers are seeing critical workforce issues that stem from, in part, stagnant wages, which is rooted in low reimbursement rates. Because 1915C waiver services are 100% Medicaid funded, it's impossible for providers to increase wages without a corresponding rate increase. We are incredibly grateful that the task force and the General Assembly recognized that without a rate increase, the crisis would become catastrophic for our system of community-based care. And the task force recommended rate increases to help providers to immediately address wages. The House generously included a rate increase for Kentucky's waiver in its budget with an effective date of July 1st, 2022. This rate increase was intended to provide emergency relief to providers while the Cabinet for Health and Family Services conducted and finalized a rate study, which would indicate the true cost of providing care. We're grateful that this increase remained in the Senate version of the budget and eventually passed. This was our lifeline. This was what would save many of Kentucky's waiver providers from closure and keep our most vulnerable out of unnecessary institutional care. The federal government must approve rate increases for our waiver programs. And unfortunately, this approval has taken much longer than expected. Here is the approval timeline as we understand it. The Cabinet for Health and Family Services submitted the required documentation for the approval of the rate increase in May or June of 2022. During the July 2022 meeting of the Medicaid Oversight Committee, representatives from the Cabinet testified about the implementation timeline for the waiver service rate increases. During that meeting, Cabinet officials confirmed that they had submitted an amendment to our approved ARPA spending plan to request approval to implement the rate increases in the budget. They further testified that, quote, "We are taking what was mandated by the legislature and going ahead and putting it in the Appendix K so that we can get that money out to providers quickly." So they put a plan in place to get that money out to providers as quickly as possible. As of yesterday, so to my knowledge, and as Ms. Smith testified, we have not received approval from the federal government to fully implement that waiver rate increase as outlined in the budget. It's our understanding that information was presented during the January 2023 meeting of the Advisory Council for Medical Assistance, the MAC, indicating that the Cabinet for Health and Family Services may receive federal approval this month. We also understand that the Cabinet for Health and Family Services will backdate any rate increase to July 1st, 2022, and will perform a mass adjustment on all claims. The situation is getting dire for many providers. While some services are currently receiving a rate increase through Kentucky's Appendix K, not all waiver services are receiving a rate increase through Appendix K. Those other services have received 0 rate increase since the beginning of the pandemic, leaving them unable to increase staff pay or recover from other pandemic-related expenses. Further, inflation has significantly increased the cost of doing business, which has a tremendous impact on waiver providers who have no ability to increase their prices. So for this reason, swift implementation of the rate increase included in the budget is vitally important. We're encouraged by the news that we may receive approval this month. We hope that that will happen, and are so incredibly grateful for the legislature and the cabinet for including the rate increase in the budget, and for the cabinet for moving so quickly on trying to get those approvals so that we can continue to support our most vulnerable citizens. That's all the information I have for you today. I'm happy to take any questions any of you might have.
Thank you, Ms. Stade. Are there any questions from members of the committee? I've got one quick question. When approval is granted, if it's granted, you said it would be retroactive.
To July 1st, yes.
Will providers have to go back and rebill all those claims, or do you know how that is handled?
I'm not the authority on this, but it is our understanding that the Cabinet for Health and Family Services wants to make this as easy as possible for providers, and it is our understanding that that mass adjustment will not be require providers to back out claims and rebill. There were concerns raised during the IDD TAC from individuals who had experienced other kinds of mass adjustments for state plan services. So we'll see how that pans out. I would hope that providers won't have to back out those claims. It would be a pretty large undertaking.
Yes.
But it's my understanding that that's not the goal.
Okay.
That the goal is for the mass adjustment to be as painless as possible for providers.
Very good. If you'll just keep us up to speed on what you're hearing out there, and see if that does become a problem.
Absolutely. Thank you so much.
Thank you. And our final presentation this morning will be an update on social worker retention and recruitment. We've got Miss Lisa Dennis, Shannon Hall, and Mary Carpenter. If you all will identify yourselves for the record.
Good morning. Excuse me. Good morning. My name is Lisa Dennis, and I am the Acting Commissioner for the Department for Community-Based Services.
Good morning. I'm Shannon Hall, and I'm the Chief of Staff for the Department for Community-Based Services.
Good morning. I'm Mary Carpenter. I'm an Executive Advisor with the Department.
Thank you very much. Whoever is first, feel free to start whenever you're ready.
Again, good morning, and thank you for the opportunity to be here today and share about DCBS. The Department for Community-Based Services is the largest department within the Cabinet for Health and Family Services. We have staff and at least one office in all 120 counties. And as you see from the map here, we have the staff broken up into 9 service regions. Currently, as of January, we had just over 4,000 total full-time employees, 4,039, and we also had 147 interim employees. We have 2 different types of interim employees. The majority of our interim hires are the traditional 9-month interims. But in December of 2021, we implemented a new hiring process, an interim hiring process that enables us to onboard new employees quickly by hiring them as an interim if they are available for immediate hire. So of the 147 interims here listed as of January, 56 of those were those interims that were in that hiring process and that will quickly move to full-time, permanent, classified employees. And of that 56, 31 were social workers. And here on this slide is just a snapshot of programs administered by the department. I will not read all of those to you, but highlight a couple. The department's responsible for the eligibility determinations for Medicaid. We oversee the SNAP program. We also, as well as the TANF block grant, the Child Care Assistance Program, the LIHEAP, or the Low Income Home Energy Assistance Program, as well as Child and Adult Protection and Foster Care, and the other programs you see listed there. In addition, we are implementing the new Employee Child Care Assistance Partnership Program that will be in effect beginning in April as part of House Bill 499. And here we look at our expenditures. On the slide, you have a side-by-side comparison of expenditures by fund type for state fiscal year 22 and the first half of state fiscal year 23. We, the first half of state fiscal year 23, have expenditures totaling just approximately $839 million. And we are currently on track to see our expenditures to exceed those in state fiscal year 2022. Here's another way of looking at that by classification. Again, you see the side-by-side comparison of state fiscal year 22 and the first half of state fiscal year 23. As you can see from this slide, the majority of our expenditures are in the classifications of grant, loans, and benefits at for the first half of state fiscal year 23. That's totaling at 539 million, followed by personnel costs at 263 million. And then here we again look at our expenditures by program type. Again, the comparison from 22 to the first half of 2023. Looking at this slide, you can see that in state fiscal year 23, the first half of state fiscal year 23, our largest expenditure has been in the area of alternatives for children at 242 million. That is our out-of-home care cost, followed by child care at 229 million, which includes the ARPA funding and expenditures. And next would be our family-based services. That is our services programming around in-home services, prevention, those types of programs. And then our next one that we'll mention is our SNAP program at 93 million.
I'm going to talk just a little bit about our child welfare services and how they're administered and where that funding flows through. So the Division of Protection and Permanency is responsible for policy oversight, contracts, our stakeholder engagement, our foster care contracts, really the programming and implementation pieces and how all that funding flows through. So we implemented Family First back in 2019. We were one of the first states to implement that. DPP is really responsible for the expansion of those prevention services. We're in the process of transitioning prevention to the Division of Prevention and Community Wellbeing. So that's a new division for the Department for Community-Based Services. DPP oversees services for foster youth, former foster youth. They actually oversee adult protection as well. This division is responsible for oversight of quality assurance activities related to federal funds that we receive, and is really responsible for all of those contracts with child care, foster care agencies. All of that flows through this division. This division is really been responsible for engaging youth, parent voice, and really seeking to engage lived experience more recently in that programming as well, in those decision making. Next slide. So this is a look at our out-of-home care numbers for really the past, since 2017, those numbers really started to trend down in 2019. Even since February, they continue to trend down. You can see 8,435 were in care as of January. Can you go back to that? Sorry. Just a look at, we saw our highest numbers in July of 2020, but we implemented a relative service array in 2019. So prior to 2019, relatives actually did not have the option, or we didn't practice relatives having the option to pursue approval as a foster home. So prior to that, the relatives, children placed in the home of a relative were not shown in our out-of-home care population. So if we were practicing today, as we were back even in 2016, our numbers would actually be lower today than they were 6 years ago. So you can go to the next slide. So this is a look at our number of children placed in relative and fictive kin. So the number placed in non-foster home are 951, and these are children actually in custody of the cabinet but placed with relatives or fictive kin. And 449 are placed in foster homes. So even that blue line, most of those are pursuing approval as foster parents. Next slide. So we, as a department, have really been committed to increasing our caregiver supports. With the support of the legislature, from Senate Bill 8, we expanded our definition of fictive kin back in from the last legislative session. That allowed us to place children from 0 to 12 months with a fictive kin caregiver and expand those supports to those families. I mentioned we expanded the relative support service array back in 2019 to allow relatives to pursue approval as a foster home. Not all relatives want to be approved as a foster parent, so some relatives may choose not to be a foster parent. In those cases, those relatives may choose to receive KTAP. So KTAP is a cash benefit for those relatives, and as a department, we have filed administrative regulations to propose increases to KTAP. So those regs are currently in process, and those are for needy families, and relatives are eligible for those benefits. We have expanded our Kinship Navigator program, so that's a federal program that states are eligible for. Those are peer navigator programs, training for relatives that are not foster parents, and we've expanded those across the state. And then we're in the process of developing a guardianship assistance program, which is also a federal program. Hopefully we can share some more about that over this next year as we're implementing that program. Currently there are 36 states with approved guardianship assistance programs. Kentucky, up until this point, has not implemented GAP, but with that implementation of the relative service array back in 2019, it really positioned us to be able to move forward with that. And it's really a permanency option where we can move forward without having to terminate the rights of parents. So we're really excited about that.
I'm going to talk a little bit about workforce updates and our recruitment and retention efforts. What you'll see here on the slide is many of our challenges that we cope with on a regular basis. I'm sure this won't be new to you, but our staff, our social service work staff especially, have that continuous exposure to traumatic events. These positions can be dangerous at times, and our staff are in positions that are high risk, similar to police and EMS. What that results in oftentimes is stress, vicarious trauma, results in burnout and compassion fatigue. They oftentimes experience secondary post-traumatic stress disorder, and all of that accumulates to result in diminished quality of services, their work capacity, and oftentimes turnover and retention issues. These triggers, unfortunately, often result in our staff's desire to leave the work and leaving us in a position where we're scrambling to fulfill the duties of our obligations. What you'll see on this slide is our turnover rates, which are reflected over the last 3 calendar years. So in 2020, as we began in the pandemic, our total turnover rate was right at 13%, and that's on a department level. But more specifically for our social service worker frontline classifications, we were just under 30%, and our family support frontline at 28.5%. 2021 was really our toughest year that I can remember in a long, long while of being with this agency. And you'll see our overall department turnover rates climbed to over 20%. Our social work frontline classifications were over 40%. So you can imagine how devastating that was to our overall workforce and our service delivery. Family support frontline classifications were again high at over 29%. But we began to see some improvements in 2022. A lot of our retention efforts occurred during that calendar year and carry us into 2023. But in this slide, you'll see that we reduced our overall turnover rate by 6%. We improved our social work frontline classifications by 7% roughly, and family support frontline dropped to 23%. So this reflects, again, specifically to our social service worker classifications, where we find ourselves with caseload carrying individuals. So on your top line, you'll see the numbers for CPS, caseload carrying workers. In December, we had 878. January 882, and February 896. So you can see a steady increase over the last 2.5 months. APS has been a little more stagnant, but you can see the numbers there on the second line. And our totals have improved to, or look like from 965 in December, January 972, and February 985. The fourth line reflects our interim positions that Commissioner Dennis mentioned earlier. We added 12 in December, 31 in January, and an additional 35 already in February, for a total of 78 in the last 2.5 months. I will add that we have an additional 32 more recommendations for frontline social workers that aren't included in these numbers. These individuals chose to be processed through the normal merit system hiring, and so they're slated to begin, some of those as soon as tomorrow, and then others on the 1st of March. So it's looking like if all of those individuals accept the position and are onboarding according to what we expect, we should have somewhere around 1,052 by around the 1st of March. Next, we're going to talk a little bit about salaries as it relates to our retention efforts. So this work really began in earnest with a December 2021 announcement from Governor Beshear, when we were able to increase entry-level salaries for both social service workers and family support classifications. That was also the same time when we implemented the new interim hiring process. So both of those things happened simultaneously. In May of 2022, The General Assembly provided for pay increases again for social service workers and family support classifications, so thank you for that. In July, the General Assembly granted the pay increases for all state employees of 8%. Again, a big help. July of last year saw the Personnel Cabinet implement a special entry rate for many of our positions. And then in January, May, and December of 2022, DCBS implemented special recruitment rates for varying classifications across the whole department, with the biggest coming in December of 2022 that really impact our social service worker job classifications and elevated the pay pretty substantially. And we feel like that's reflected in these most recent numbers. And DCBS is currently in the process of increasing all department salaries to 90% of the Personnel Cabinet's midpoint for each job classification. So staff supports. Staff support. So one of the things that we did around November of 2021 is we were successfully at implementing a shift premium. So a lot of our social service worker staff, their job isn't Monday through Friday, 8 to 4:30. These type of events happen all hours of the day and night, 7 days a week, 365 days of the year. And so we were able to implement a shift premium to help with paying these individuals an extra $5 an hour for those extra long hours that they work, investigating these on-call type referrals on weekends and late at night and evenings. We were also successful in May of last year of acquiring a locality premium for the Jefferson County and Jefferson Service Region. That has traditionally, for many, many years, been our hardest area of the state to retain staff and recruit staff. And so we were successful in implementing a locality premium of $4 an hour for those individuals that provide these direct services in the Jefferson Service Region. We've continued with our flexible and hybrid work schedules. We have piloted shared caseloads in different areas across the state, which allow case continuity in the event that a staff member needs to be out for an extended period of time, or if they leave the agency, there's someone who's familiar with that case and can pick up and provide some continuity to that family moving forward. We've really started acting upon our recognition of that secondary trauma and implementing practices around really having staff focus on their own self-care and well-being as they do this work, having a plan to do those things, to revisit those things with their supervisors on a regular basis, to talk about the impacts the work is having on them personally and how they can mitigate some of that with their own practices and with the help of the agency. We also were successful in lobbying some regulation changes around critical incidents for our staff. So when they are involved in an incident that threatens their physical health or well-being, we now have the authority to grant those individuals short-term leave to sort of take care of themselves and process that event. And then we also have some new initiatives to address caseloads, specifically alternative response and community response. This is basically accomplished through some partnerships with families and community partners to facilitate some sustainable pathways that has community members respond to some of those lower level incidents to sort of help the agency, the department, handle those cases in a upstream and preventative type approach. Okay. So our recruitment efforts. Again, I'll mention the interim hiring process that we began in December of 2021. That has been very successful, and you've heard the numbers there. We continue with our public child welfare certification program. This has gone on for many years now, and many graduates have been produced through that program and have worked for the agency through the years. We fully implemented a co-op and internship paid program for students. So those students who are in programs related to the work we do can now come to the agency, work for the agency, learn what we're all about, what the work looks like, and hopefully upon graduation they will be interested in coming to work for us. Right now we have 22 of those individuals just since we began this program with this newest spring semester. We're constantly targeting colleges and career centers to look for those next group of potential employees. We frequent career fairs, both in person and virtually. We fully utilize LinkedIn and the handshake apps to sort of advertise our work and get the word out there that we're hiring on a frequent basis. For the past several years, we've been to the state fair where we've put forth some pretty concerted efforts around recruitment. And we currently have, it's a new day recruitment campaign that we began toward the end of 2022, and currently have daily ads running on over 100 radio stations across the Commonwealth, talking about our vacant positions, our open positions, and encouraging folks to apply for those positions. Next. So building a 21st century DCBS. We want to continue our robust in-person and virtual workforce. The feedback is overwhelmingly positive about the structures that we've put in place to provide sort of that balance for our workforce. We've really began to look at open concept work environments and taking a look at some of our brick and mortar buildings, taking better care of those and sort of upgrading accommodations where we can do so. We want to continue the flexibility with the initiatives around work-life balance. We continue to revise and modernize all features and physical conditions, again, of the DCBS work that we perform. We fully incorporated lived experience from our trusted advisors. We want to know from those who have been in situations where they have come to be in service from our department and learn from things that we did well and areas that we need to improve. And a living example of who we are as an agency and what and who we value.
And just as we wrap up, we want to make you aware of sort of a unique challenge that began last year. We started noticing in May of June of last year a trend in really not being able to find placements for youth who have unmet sort of complex needs. We call these high acuity youth. So these are youth that have intensive behavioral health needs. They tend to be adolescent. They tend to be committed for dependency rather than abuse or neglect. Tend to have aggression, autism, racial disparities. So they tend to have certain characteristics, and we began tracking those in May or June of last year as we started to struggle with really finding placements, and our staff were struggling with these.
So you're meaning violent? Is that how you would?
Aggression towards themselves, others, and property.
Okay.
Yes.
Thank you.
So when I say we're not able to find placement, this is just a snapshot of reasons why we're not able to find placement. So for December and January, and this is a snapshot of all referrals for children in out-of-home care. We may do upwards of 30,000 to 35,000 referrals for all children, as we're looking for a placement for children. So we're making referrals to our agency partners to be able to search for a placement for those children. So when we're talking about unique children, we may be looking at 417 children to approximately, for January, we had around 547 children. So unique children. So then of those children, between 90% and 95% of those children are being rejected for referrals. So what this slide doesn't show, though, is we've been meeting with our providers, and providers are struggling with staffing. They're struggling just like we are with hiring quality staff and capacity issues as well. And our bed capacity is actually lower than 50%, but the staffing is a concern for our providers as well. And then when you think about children being referred, they're being referred on average between 65 to 68 times before we're actually closing out those referrals. The reason the top reason for denial is aggression, the first reason is age. Most of these kids are between 13 and 21, and then the second reason is aggression. The next slide. So since June of last year, when we really started to notice this, we saw the number of children being referred out of state double. At this point, other states are having the same issue. Most of the kids ended up staying in state with our own providers, but we did initially see the number of children going out of state double. Number of children around placement instability, that has also doubled. We're seeing hospitals refusing access or admission for DCBS committed youth. And then, of course, children sleeping in offices, having to stay in hospital emergency rooms. So this is, an undue burden on our staff, something that we're really focused on finding solutions and strategies for.
Okay, so as we wrap up, excuse me, you have heard from Shannon and from Mary, who have described two. So sorry. So you have heard from Shannon and Mary as they describe two of our most significant challenges within the department, our workforce capacity and our needs for services for our high acuity youth. As Mary stated, these are not challenges that are unique to Kentucky. When we talk with our peers from child welfare agencies across the country, they are experiencing similar challenges that, again, are similar to Kentucky, and some are even more significant. So in these final two slides, I'm going to describe some of the steps we've taken currently and further needs to tackle these issues. Shannon has touched on a lot of our workforce initiatives, so I'm going to focus more on our steps taken around to address our high acuity youth. However, these two issues, as Mary stated, are very connected. Our lack of services and resources to support high acuity youth adds to additional stress and drain on our workforce. If you are that frontline social worker with a high acuity youth in crisis or in imminent need, it becomes all consuming. Oftentimes, that's all the worker can focus on for a number of days, and it is also impacting other staff within the service region because it's taking multiple staff to meet the needs of our high acuity youth. So I do, again, want to take just a minute to recognize our frontline social work staff and our service region staff. They have done a phenomenal job of responding to the needs of our high acuity youth and taking on additional workload and stress. And they do it without complaint, and they truly are. You've heard us say it and describe them as those everyday heroes, but we can't say it enough. We've had a tremendous workforce and appreciate all that they do. So to better support youth in need and our workforce, some of the steps that we have taken to address these issues is when we first began hearing of children placed in these non-traditional settings, this was new to us. We hadn't experienced this previously, so we immediately came together, began discussing, where are the gaps, what are the needs, how do we support our youth differently, how do we support our providers differently, what does this look like? And a lot of good work began to happen really quickly. But what we recognized is that it all wasn't coordinated or connected. So we have hired a high acuity youth coordinator who sits in central office, and her responsibility is to be the point of contact for all things around our high acuity youth who are in imminent crisis. And we also recognize, to support our workforce, that this work needed a similar approach and model in our service region. So we're in the process of hiring additional high acuity specialists in each of those 9 service regions, again, to support the work and to get upstream, thinking about identifying those early entry points and how we can put services around children sooner and quicker so that they do not end up in crisis and in need of a non-traditional placement. And part of this work has also included a daily call. So every day at 8:15 in the morning, staff from DCBS, but not only DCBS, a group of core committed partners from other agencies come together that include, again, DCBS, our regional staff, the MEDICAID is with us, Department of Behavioral Health is on those calls with us, along with Aetna Sky, our managed care organization, and other providers as needed. DJJ has joined those calls when appropriate. Again, the purpose is to put a plan around the immediate needs of that child who is either in a non-traditional placement setting, such as our office or hospital, or is at imminent risk of becoming in one of those settings. So that work has been since the beginning of the year, and while we are not at 100% in diverting all of our children from non-traditional placements, we have been able to divert many children from needing some of those non-traditional settings. So that is some of the work that we've been immediately to do. We've also, and the other points on this slide kind of fold into that. We have also began working with our providers to look at enhanced payments. So what additional therapeutic services, supports, resources are needed to be able to keep a child in a placement. We're working very closely with our community partners. Like I said, we've engaged our regional leadership in identifying appropriate placements for youth. And we also have a number of work groups and committees that are looking at the short-term needs, but also looking at the long-term changes that need to take place to fill the gaps and build out a continuum of care that meets our children's needs. And of course, we're working very closely with Aetna on Sky, which is our managed care organization for all children that are in out-of-home care. And finally, we talk about our further needs, looking at service challenges and gaps. We are identifying ways to support our providers, our provider community, which includes the review of payment models and reimbursement supports. We are also looking at how we support our workforce supports, both for DCBS as well as for, again, providers. Continuing to identify ways to move upstream with a focus on prevention and early identification. We can never have enough community-based services, access to which could include increased access to telehealth, mobile crisis, respite care, and really looking at building a system of care around the youth and families' needs and helping them to access services when they need them and where they need them. As we look at addressing the placement challenges and bed capacity issues, we held a convening on December 9th with the leadership from our private child caring provider community. We shared data and discussed the capacity needs within our continuum of care. We asked providers, and providers shared, again, what they were experiencing and what their needs were. We asked them to submit proposals for how they could support the gaps and help us build capacity. So we are beginning to receive some of those responses, and we are reviewing their proposals. And when we talk about overlapping and cross-system involvement, we know that many of our high acuity youth are cross-system involved. So one example of that is, a high percentage of our high acuity youth are also involved with DJJ, either currently or past, or they're court involved and coming into care related to status offenses, but they also have significant mental and behavioral health needs. So looking at ways to increase opportunities for cross-system collaboration is where we need to continue to work. And a couple of good examples of where that's already happening is with SEAC and the newly formed Judicial Commission on Mental Health. So as I close, I will make one final comment. We must continue our work collaboratively to better meet the needs of our workforce and our youth. Our system should not result in youth presenting with complications or consequences related to placement, availability, or stability beyond what the concerns that brought them to the attention of the Child Welfare Agency. Youth and families deserve a range of pathways towards a resilient future. We have the right people. We have the support and commitment from all levels. The Secretary's office, Secretary Freelander, is very involved and supportive. The Governor, the General Assembly has been very involved in supporting our child welfare system. And we can't say thank you enough for everyone's commitment in helping us move upstream and building a system of care that will better meet the needs of our children. So, any questions?
Thank you very much. I do have a few questions. On the workforce increase, the caseload carrying, I guess, workers you have or employees you have, is that, I see it's increasing. That's a good thing. Is that happening across regions, or are there others that are further ahead and some that are falling behind?
It is happening across regions. Of course, recruitment is more difficult in some areas of the state than others. Mm-hmm. Particularly Jefferson County is really difficult. Fayette County has been difficult at times, some areas of northern Kentucky. The competition for individuals that qualify for our positions are more in those areas, and so we have seen some successes all across the state, but it is a little easier to recruit in some areas than others.
Mm-hmm. And the $4 increase for Jefferson County, is that affecting surrounding counties?
Our approval
as far as surrounding counties' workforce, are people leaving, say, Shelby County or Bullitt County to go?
We really haven't experienced that.
Okay.
We thought we could when we first undertook that whole initiative, but it's really not played out like that. Now, we have been able to pick up some positions in the Jefferson service region as a result of it, but we don't think or we haven't seen individuals leaving those surrounding counties mm-hmm. for that additional pay.
Right. And then I guess lastly, you hit on it on the end, the high acuity youth problem. Obviously, that's a workforce issue. It probably involves juvenile justice to a degree, and you all working or us figuring out fixes for that to help you all as well. Outside, I know you can't take that away, but is that the largest remaining obstacle as far as like workforce and keeping people workforce retention?
The high acuity youth?
Yes. Is it wearing people out to a degree where they're just like, I'm done?
It is additional stress for our workforce. I don't know if I would say it was the number one reason why we are seeing staff leave, but it's definitely additional stress. It's additional worry for our staff as well, and something that we need to address for both our youth and their well-being, ensuring they have the services that they need and timely to address their mental and behavioral health needs, but also to help support our workforce. I think it's a variable, but probably not the most significant.
Okay.
Would you?
I would agree, and you know, we poll our staff pretty regularly. We survey them, and we ask them, you know, what are some of the things that you enjoy about working here, and then where can we improve? And if you look back at that data and you look at the years 19 through 21, before the pandemic, a lot of the reasons we heard that staff leave was a better job outside of state government, higher pay, the retirement, lack of promotional opportunities, things like that. And we've seen a shift a little over the past year to year and a half, where the reasons we hear of our staff primarily leaving is workload, not enough time with family. It's not some of the same reasons. Now, they still count some of those, a pay, a better job, and things like that, but they're not at the top of the list where they once were.
High acuity youth, is that regionally? Is that concentrated in a few areas? Is it spread out across the board?
It's across the state.
Okay. And you mentioned community partners, work groups, everyone getting together, different cabinets working together to try to solve this issue. Do you plan to have recommendations at a certain date, like for the legislature on that, as far as the steps to take to help solve this issue?
We have a number of work groups that are putting together recommendations. So I think as we begin to build out our budget request, we may see some of that reflected there.
Okay. And as you sit today, I know you always would advocate for more resources, but I mean, do you all have what you need today to do your jobs?
We are looking at workforce supports probably a little bit differently than what we have in the past. I mean, we, thanks to the General Assembly, we have the budget to hire additional social workers. So it's the recruitment and retention pieces that we're really focusing on. And then when we're talking about workforce support, so so for example, the high acuity youth and how we're putting services and supports around the workforce with additional staffing positions, we're looking at that. We're also working on adding positions within our service regions to work alongside. They will not be social workers, but it's a job classification that would work alongside that social worker and help support the worker and the family in meeting the family's needs. Think of it similar to like a peer support model. The employee would again be assigned to the family and would help them work on identified needs. An easy example would be truancy. So helping the family identify barriers and solutions. If it's transportation, is it scheduling, is it what that may be. And that's a very simple example. But again, a support to the social worker to help have additional resources in that home, additional eyes on that family, and helping that family remain connected to resources. So we're thinking about things like that. And then we're also looking at the way we manage. Shannon talked about community response and alternative response. So implementation of those models where we're moving upstream. So those referrals, for example, community response. So those referrals that did not meet our statutory definition for allegations of abuse or neglect. We're currently piloting in a handful of counties a community response model where they would be referred to a community partner. The community partner could engage the family and hopefully provide them with supports and resources so that they never come to the attention of the Child Welfare Agency with a concern that would meet the definition of abuse or neglect. And alternative response, again, looking at how we work with families differently, engage them earlier, engage them in a different approach of collaboration on some of those lower risk referrals. So those are the things that we're currently working on that will provide workforce supports in a different way.
Mm-hmm. But, implementing, getting better within, your agency, you're always going to be doing that. But do you have the resources you need to implement those plans?
Thanks.
I think potentially, especially with community response, we may be asking, we're currently doing a formal evaluation on that.
Okay.
We may be coming to you asking for an appropriation for that. We do hope to expand that statewide. We want to be able to provide you with, outcomes for that before we do that.
Okay.
Today we have the support for that. The same will be for guardianship assistance potentially.
Okay.
So I think today we have what we need. Potentially in the future we may be, we want to be able to provide you with the outcomes for those, but
Right.
potentially in the future we may be looking for support for those.
And the same for prevention too. We currently have, I think, what we need, but as we expand and implement further, I think there'll be opportunity to reach back out for additional appropriations there.
Very good. Thank you all for your work.
Thank you.
All right. And with that, we are adjourned. Thank you very much.